The point that's important to note is that surgery remains the most important and the best treatment for patients with localized non-small cell lung cancer. But having said that, this picture here clearly shows that a significant proportion of patients will relapse after surgery alone. It doesn't matter whether you're stage 1B or 3, as the stage keeps going up, your probability of getting the disease back keeps increasing, and that ranges from anywhere between 45% to about 76%, depending upon the stage. So the first question is there a benefit at all for platinum-based adjuvant chemotherapy? And here we are referring to a platinum doublet. This is the LACE meta-analysis that was published a really long time ago, which clearly shows that there is a 5% benefit in terms of overall survival at the end of 5 years. The hazard ratio there is 0.89, which means there is 11% relative risk reduction, and that's not really a big number. Now, this is the forest plot from the LACE meta-analysis. Now, the two arrows point towards the two studies that clearly showed that there is an overall survival benefit, and these are the ANITA study and the JBR10 study. Very important to note that both of these studies actually used vinorelbine as the partner with cisplatin. Now, the other studies had a hodgepodge of many drugs. In fact, some of them had even paclitaxel, carboplatin, so on and so forth, but none of them really showed overall survival benefits. Again, the hazard ratio for the whole group is 0.89 as shown earlier. Now, I think this is much more important to note that the benefits or the magnitude of benefit of chemotherapy in early or operable lung cancer is very much dependent upon the stage. Now, we said 0.89 is the hazard ratio for the whole group, but look at what happens when you dissect it stage by stage. Stage 1, hardly any benefit at all. While when you come to stage 2, you've got a 0.73 as the hazard ratio. When you go up to stage 3, it even gets better. So the point I'm trying to make is that when you're looking at the hazard ratio, the ratios get better as the stages keep going higher. Now, I think this is a very beautiful representation of the absolute benefits of chemotherapy. We spoke about the relative risk reduction in terms of survival, but here we are showing the absolute benefits of chemotherapy. Now, for you to clearly understand, this is stage 1, 2, and 3. When you're talking about stage 2, you're talking about tumors that are more than 4 centimeters and any lymph node that is positive within that subgroup. Now, as you go down these blocks, let's start with the LACE meta-analysis itself. As the hazard ratio we showed got better with the stage of the disease, the same is the case with the absolute benefits. 3% benefit for stage 1 in terms of overall survival, 10% for stage 2, and 13% for stage 3. Now, remember that we adopt therapies in breast cancer so easily, even without overall survival benefits. But here in lung cancer, some people at least are hesitant to adopt with such good overall survival benefits in terms of the absolute benefits. Now, the other important point that I want to make on this slide is that the two studies that showed an overall survival benefits by themselves also showed that you could have a detriment. 7% of patients actually died while on therapy. 4% of patients actually died while on therapy. So on one hand, you have benefits that keep increasing with the stage. On the other hand, you can end up harming patients, especially if you're early stage, and that can compromise the outcome. So the magnitude increases with the stage, but be very careful when you're in the early stage bracket. You could end up harming your patients very easily. One of the areas of controversy is what do you do with patients who have a tumor that's between 3 and 4 centimeters? One of the recommendations is that if you have a patient in this group, and then you got your pathology, and you found that one of this was there in the pathology, visceral pleural invasion, lymphatic, neural, or vascular invasion, or certain specific histologies, then chemotherapy may be recommended for that group of patients. But please remember that these are prognostic factors. The predictive value has been looked at in post hoc analysis. Now, this was not planned subset analysis, and we don't have prospective studies here. So if you have somebody between 3 and 4 centimeters and you've got one or more of these risk factors, you may be tempted to do adjuvant chemotherapy, but that has to be an individual decision, and we cannot generalize there. What are the other important questions of clinical relevance? Which regimen should we be using? All these trials used platinum, so it should be a platinum-based regimens. What about the other regimens that are there? We think they may be good enough, but as we said, these are underpowered to look at what regimens in that trial were actually beneficial versus not. Now, a lot of us have changed to pemetrexed and cisplatinum, right? From doing vinorelbine cisplatinum because of logistics, side effects, cost, and so on and so forth. There is a nice study that was read out at ASCO last year, which clearly showed that pemetrexed cisplatin was as good as vinorelbine and cisplatin. So you don't have to be worried that you're using something that does not have randomized high quality evidence. Now we have good evidence to use this. This was a Japanese study though. Should you use cisplatin or carboplatin? Ideally, it should be cisplatin. Now, is there again randomized evidence? No, it is purely a consensus based, because all of us know that cisplatin is a slightly better drug. And when your intent of treatment is cure, you always do the best drugs available. What about number of cycles? 4 cycles is good enough. There's no 6 cycles, at least in lung cancer. How quickly should you be starting? I think various trials have randomized patients till a wide period of time, starting from less than 60 days, that's about 2 months, to about 16 weeks in the Ontario registry. So we don't really know as to whether a delay is going to cause a compromise. But I think the more important point is that even when you see somebody at 3 months or 4 months, you could still take them onto the adjuvant therapy protocol, whatever you're using. I think that's a very, very important practical point. Now we leave surgery and get on to SBRT. Now, what is the role of adjuvant chemotherapy after stereotactic body radiotherapy when you have found a solitary pulmonary nodule, or in a patient wherein you're saying that he or she is not fit for surgery, so I want to do stereotactic body radiotherapy? Now, there isn't good evidence to substantiate the use of chemotherapy here, so we need to extrapolate. So for me, this is the way I look at it. If you believe that there is equipoise, patterns of recurrence are similar, and the recurrence rates are comparable. When I say comparable, I'm talking between surgery and SBRT. So if you believe in these 3 points, then adjuvant chemotherapy after stereotactic body radiotherapy is justified for the medically fit patients with indications similar to post-surgery. Now, indications, 3 centimeters with some specific poor prognostic factors on the pathology, and anybody more than 4 centimeters. So that 4 to 5 centimeter bracket in SBRT would qualify for adjuvant chemotherapy. At least that is my simple interpretation of the literature that is available. And finally, no talk today is complete without Adura. Now, this is looking at the value of osimertinib versus placebo in patients with operable lung cancer post-surgery in patients who have an EGFR mutant. These are common mutations here. Now, the important point to remember is that 50% of patients who were randomized did not receive adjuvant chemotherapy, which we would consider as the standard of care. The primary endpoint was disease-free survival by the investigator in stage 2 and 3A patients. Now, you can't ask for a better hazard ratio and separation of curves. That's a dream disease-free survival benefit, the hazard ratio being 0.17, but the maturity is only 33%. The overall survival events are even lesser, but what you can see here is that in terms of preventing a recurrence, not necessarily preventing death, it seems to be a phenomenally effective therapy for patients who have an EGFR mutant disease. But having said that, there's a lot of criticism behind this study. So let's look at the good, the bad, and the ugly of the ADAURA. What's the good? Brilliant disease-free survival, benefiting all subsets. It's a blinded trial. And of course, all of us who have used osimertinib would clearly be testimony to the fact that the adverse event profile is very, very favorable. What's the bad? No overall survival benefits so far. And half of these patients did not actually get standard of care, but the forest plot clearly shows that whether you took chemo or you didn't take chemo, the disease-free survival benefit was still there. One of the important things, as they say, the elephant in the room, is how many patients actually took osimertinib for 3 years. We still don't have that data. What's the ugly? Imagine taking osimertinib for 3 years. You would just burn a big hole in whatever pocket you ever had. So to conclude, stage 1A, no adjuvant therapy is recommended. Stage 1B, consider with high risk features, and it's not for all patients. Stage 2AB and 3A adjuvant cisplatin-based chemotherapy is recommended. Consider osimertinib for 2 to 3A if your patient has an EGFR mutant disease. The role of SBRT is unclear, but as I said, if you extrapolate the results from surgery, then you would use in the same subsets that you would use chemotherapy after surgery.